So for acute respiratory distress syndrome, no matter what the cause might be that caused the patient to have this, the symptoms will usually be the same. So interstitial and intraalveolar edema and hemorrhage will be seen. So inflammation will be seen in patients. Alveolar consolidation, so fluid in the lungs. Pulmonary surfactant deficiency may be seen, and atelectasis will be seen because of that fluid built up in the alveoli. Um, so ARDS usually appears within 6 to 72 hours after the inciting event. The patients will present with shortness of breath. When you listen to them, they'll have bilateral crackles. They might look cyanotic. They'll have an increased heart rate. And there are more than 60 possible pulmonary insults that have been identified to cause ARDS. But there are some common causes that are mostly seen, and sepsis is one of the biggest ones, and this can be due to organ failure, so the lungs are starting to fail, and aspiration is another common cause. So 1/3 of patients that aspirate the gastric content in their lungs will get ARDS. And then pneumonia is the most common cause outside of the hospital. And then severe trauma, this can be a patient that gets in a car accident and gets they get in a car accident and then they get a steering wheel to the chest. So anything like a blunt force trauma to the chest can cause ARDS too. So for diagnostic criteria, the Berlin definition is used for diagnostic protocols, and this is used to diagnose the patient with ARDS. So they have to have at least some of these symptoms. So new or worsening symptoms over the past 7 days. Bilateral opacities will be seen on the chest x-ray, and this is very similar to pulmonary edema. So their chest x-ray will look whited out and have that ground glass appearance to it. And then patients' respiratory failure cannot be fully explained by heart failure or fluid overload. And then moderate to severe impairment of oxygenation must be present, and this is one of the biggest things with ARDS patients. You will see that they require high FiO2 levels and high levels of PEEP. And then they made a scale to determine whether it's mild, moderate, or severe, and they base this on your PaO2 ratio divided by the FiO2. So a mild ARDS symptom will be greater than 200 millimeters of mercury but less than 300. And then moderate will be a PaO2 divided by FiO2, and that's greater than 100 millimeters of mercury but less than 200 millimeters of mercury. And then severe is where a PaO2 divided by FiO2 is less than 100 millimeters of mercury. And then some clinical manifestations that you will see, some vital signs, is increased respiratory rate. This can be due to low levels of oxygenation and they're just trying to catch their breath. Hypoxemia, decreased lung compliance. So this is where the low tidal volumes come into play, and we don't want to overstretch their lungs. Anxiety will be present, increased heart rate and blood pressure. Cyanosis will be present from the hypoxemia, and when you listen to them, they'll have bilateral crackles. So ABGs for ARDS patients, mild to moderate, they'll have a pH that is increased, CO2 that is decreased, PaO2 that is decreased, and a bicarb that is decreased. And then for severe, they're just in respiratory failure pretty much. Their pH is decreased, the CO2 is increased, and the PaO2 is decreased, and the bicarb is decreased. So this right here is a chest x-ray of a normal person. You can see their costophrenic angle. You can see good aeration. And then over here, you can see, like I was talking about earlier, the whited out kind of ground glass appearance. There's a lot of consolidation. You can't make out the costophrenic angle, so there's some consolidation going on. And some scarring. So This is normal, and that's the ARDS patient. So some general management, because these patients won't be able to support their own ventilation, mechanical ventilation is usually needed, and low tidal volumes and high respiratory rate is used to keep a normal minute ventilation. So we'll start between 4 to 6 milliliters per kilogram of ideal body weight, and then because of the low levels of oxygen concentration in their body, oxygen therapy is needed. And then lung expansion therapy, so for example PEEP, will be needed as well to keep those alveoli open and help the patient receive better gas exchange.